your comments.
Okay, thank you, David, very much. Can everybody hear me okay?
Yep, I guess we're okay.
Oh, okay, great. Thank you for the generous introduction, and I wish I could be there with the group today, but it just didn't work out travel-wise. I also, David, want to thank you and George Isham for serving as co-chair of the roundtable and for the IOM to initiate it, obviously, and the support of Dr. Flores and the California Endowment and other supporters. It's really very important work and couldn't be more timely. So what I'm going to do, I'm very conscious of the time there, and you all need a break for lunch. I'll go through a few slides, and in a way, I realize I'm preaching not only to the choir, I suspect, but to the clergy, in that many of you are doing the things that I'll simply underscore and maybe offer a few more ideas and elaborate a bit more on what we're trying to do out here in California. The first slide, if we could key that up beyond the title slide there, is really, I don't know what the weather's like in DC today, but is the sunlight really pouring through here for population health? And we all know that in the original legislation, there was about $10 billion over the next many years for a variety of activities, and we also know that a lot of that money is vulnerable in terms of budget issues and so forth. But with that background, if we go to the next slide, I really want to make an important point or underscore what people there I'm sure understand, and that is, in this country, we need to move from a culture of sickness to a culture of care. I would argue that probably we're in the midst of making that transition. 20 years ago, 30 years ago, the work of Don Berwick and a lot of others, people in the room there, to improve the care process and make people healthier and eliminate waste. But we need to move on from that to a culture of health. And given we're in the United States, that means how do we create a market for health? We have a market for disease. People compete on that. We have a market for care, I would argue. We do not yet have a market for health. And that involves changing fundamentally what we pay for and how we pay for it. When we start paying for health and wellness, we will create markets for health and wellness, and providers and others in the communities will develop capabilities to respond to those new incentives. And I think that is at the heart of our challenge. So if we tee up the next slide, the key is changing the payments. We need to pay for technology-enabled, team-based systems of care to keep people well. And there's so much talk now about patient activation and engagement, and it's very important. We have a long ways to go, but we need to go beyond that. What we really need is people engagement. We do not want people to become patients in the first place, and that's going to require the community-wide, population-based approach that I think you've been talking about this morning. It's what the roundtable is all about, and it's not just about the individual accountable care organizations or integrated delivery systems. As I point out in the JAMA piece and others also, when they talk about population health, it's about their population of enrolled patients. And that's great, and they need to take a population focus to that. But we're really talking about community-wide health in all policies and the pillars that produce healthy people, and that begins with healthy communities. So this is the challenge, is how do we develop the incentives for that to occur? So when that occurs, the next slide, you're going to unleash all kinds of innovation. When people don't have to worry and haggle about fee-for-service and who's going to do this procedure or that procedure, etc., you've earned the money up front, risk-adjusted, quality targets. We can argue about what the budget might be, but every incentive in the world now to keep the community healthy, to keep people healthy, and to keep them as people, not patients. If they become patients, then every incentive in the world to work with them to recover their health as quickly as possible. The next slide, and the next several slides, in the interest of time, I'm just going to kind of skip over. What they are is just a reminder of some of the things in the Affordable Care Act. And one of the things that the roundtable might do, or IOM staff, or maybe others are doing it, is to begin to chart how much of this is getting implemented and where we stand on all of these things that are in the Act. So you see the workforce issues there, community transformation grants. The next slide shows some of the prevention activities and employers and schools. The next slide, if you look at that, and again, if there were more time, we could go into these, but I think these are familiar to all of us. So again, the prevention public health approach, some money's in there for that. So if we go to the next slide, it's the population-based health continuum goal. And as David has alluded to, this is something that, and I was very much influenced by David's book on Pain for Population Health a number of years ago. But this is an adaptation of one of the books we did a while back, a concrete way of looking at a roadmap of what this involves. So people talk about communities, but what are communities? If you look at it, it's really a group of individuals with a sense of shared space, shared responsibilities, and perceived interdependencies. It's more than just geography or where roads are built and so on. And so this word community is thrown around a lot, but we probably have a lot of multiple communities and sub-communities within, obviously, Portland, Oregon, and the Bay Area of San Francisco, and Madison, Wisconsin, and so on, Washington, D.C. But the community, and then the assessment of the assets we have to keep people healthy. And this is the health and all policies. They're not all on there, but I listed at least some of the more prominent ones, of which the delivery system is a part. It's a pretty small part, percentage-wise, as we know. And what we really want to do is move the chronically ill that account for 75% of our healthcare expenditures in this country to the left, right? Make them at least sporadically ill, but go all the way over. We really want to be in the business of creating a market for health, the chronically well, if you will. The sporadically ill, move them to sporadically well and chronically well. The sporadically well to chronically well. That's population-based health continuum goal, okay? Creating the chronically well. If we go to the next slide, it shows it a little bit differently of what some of the building blocks might be that many of you are implementing. And if we start at the top, we have the community health-based needs assessment. Some states have been doing these for years, and now it's essentially mandated. We have to identify the assets and capabilities that we have and the resource requirements and what the gaps are. But the big thing is that alignment that is only going to come about through payment policy, let's face it, of aligning the goal here of keeping people well. Providers, managers, governance across medical health and community sectors. And then there's something that we call the capability wheel. It's the hard work in the trenches of really taking our knowledge about desired end states, what we want to achieve in reducing childhood obesity, what those targets are. In California, under the governor's initiative of Get Healthy California, we have 6 work groups, and we've defined targets for the state. I think this was alluded to earlier, over the next 10 years. And it was a very fast process, a very extensive process, but we need to know what it is we're trying to achieve, and then develop the strategies and action plans, continuous quality improvement, measure results, and the information systems critical that we don't have enough of now that tie this all together. So this is a wheel that once you get it going, it's hard to get it going, but once you get it going, begins to gain momentum and becomes a positive, virtuous cycle of a self-fulfilling prophecy in the desired direction. So it's just a visual to show, I think, some of the things we're trying to do. And the next slide is for managers and leaders, may or may not be a tool useful to you. Some have found it useful. If you ask yourselves, why are things not happening as fast as you hope they do in Madison, or Vermont, or Washington, or Portland, Oregon, or whatever? It's these 4 pillars. Is this really a priority for your community, given other competing priorities like jobs, okay? Are the structures in place? Do you have the right people at the table to get it done? Is the culture in place around people's understanding of the contribution of wellness and health to the local economy and reverse causation to creating jobs? And then are the technical skills and the information systems in place? And the point of this stylized slide is simply that in the first row there, you can have all those other things in place, but if it's not really a priority, you're going to get the result on the right-hand side. I think all of us can identify with that result. These are probabilities, 0 to 1. Of course, it's usually in between. The second row shows everything in place, but you don't have the structures to make decisions. You don't have the right people involved, and you're not going to be able to capture the learning as you go along. You don't have forums to capture the learning. The right hand or this group doesn't know what the left hand or the other group is doing. In the third row, okay, you're going to get temporary results and slide back. There's no celebration of what's going on. There's no visibility in the local media, et cetera, et cetera. The cultural norms surrounding what you're trying to do aren't there. And in the fourth row, you're going to frustrate a lot of people because they don't have the tools or skills to pull it off. And the point being, it's that bottom row that we have to aspire to, where all of those pillars are aligned. Maybe not perfectly, because that's where you get the sustainability and that's where you get the scale. So it's just a kind of a matrix that may be a tool in asking the question, why aren't things happening as fast as we think they should? So let me begin to kind of head toward the end here with what some of the changes are, I think, in the next slide, delivery system changes that need to occur. And we elaborated on these a bit in the JAMA piece. So if you're on the healthcare side, you have to totally redefine your product. No longer is it illness, it's wellness. I'm waiting, and I think a prize ought to be given to the first community that develops a billboard next to their freeways that shows a hospital bed with a red cross over it. An empty bed is a good bed. We keep you well. Okay, I'm still waiting for that first billboard because that's what we're talking about. The business model now changes for hospitals and delivery systems, and you don't want people in those beds unless, of course, they really need to be there. So it's from patients to healthy people. The place is wherever people are. It's not the office necessarily, the clinic or the hospital bed. It's the home, the workplace, the school, where we all live our lives. And we have to redefine what we mean by providers. There's a whole range of health professionals, but there are our teachers, our social workers, our architects, our urban planners, our community development specialists. These are all creators and assets for health. The next slide just gives you an idea. Some of the early evidence around one component of the changes on the delivery side are these primary care medical homes. Many of these are randomized trials, and Karen Davis pulled a lot of this together last year. The actual original citations I should have put on here, and I can get them for you. Some of you may be aware of them, so I apologize for that. But this is just a quick run through of what some of the patient-centered primary care medical homes are achieving around the country: reduction in visits, et cetera, reduction in costs. The next slide continues that, and you can look at those at your leisure. We even are beginning to see mortality declines from some of this. The Massachusetts experience, of course, and out in Utah as well. So the next slide talks about the tools needed, what's going to be needed for this population health data management. We need individual health status data. We need to work on all payer claims and what's in there. We need to work on the HIPAA concerns and privacy, clearly. We need much more predictive modeling and stratification on who are really the chronically ill, the 550, the 553. In California, we know that 5% of our expenditures, or rather 53%, are accounted for by 5% of our population. Nationally, I think that's 550. We know it's the dual eligibles. We know it's the frail elderly. We know it's the mentally ill. We know it's the homeless. We need to target interventions, and that's the next point. And also around prevention, we need to be much more better at targeting where prevention is going to pay off, rather than across the whole landscape running up costs of prevention when half the people really aren't susceptible anyway. Okay, so we need to be much more sophisticated in our thinking around prevention. And you can see some of the other things there, the workflow tools, lean production, and so forth. The work of Theta Care out of Wisconsin being an example of that, course, the Institute for Health Improvement as well. And then the next slide is on the public health sector changes in our state and local health departments and community health agencies. Much greater flexibility in use of funds, new partnerships that need to be struck that health departments and others have not forged before. Again, the better targeting of our preventive services, joint development of goals and metrics to measure progress, and a shared infrastructure. I mean, why shouldn't integrated hospital health systems, if their goal now is wellness, begin to share and make staffs permeable between the so-called hospital and health system and the health departments and the FQHCs and the community development agencies? So we need to think of the skill base of the community very differently, but there's no incentive to do that unless we're working towards common goals and a common financial model in which all are going to benefit as a result. And the next slide is around the community development social service sectors. David and others have mentioned the September meeting is going to dig down into the health and all policies. Very much is what we're about here in California, and I know other states as well. And the health effects of zoning, housing, transportation, labor, and education. And one of the things that I've come to realize, and you probably a lot earlier, is we can't just talk to these other sectors in terms of this is what you need to do to improve health. We also need to realize what their strategic agenda and priorities are and how they're getting rewarded, and how what we do in health can infiltrate their strategic priorities. So it needs to be a two-way street, not just, hey, don't you understand the health game here? We also have to understand how what we do in health can contribute to these other sectors achieving their goals and their budgets and what their incentives are. And that sometimes takes a lot of work. So here are some examples. Some are in the room there, and we don't have time to go into these, but you do in your discussions. Cambridge Health Alliance, the RWJ work they're doing with the Federal Reserve Board and human capital investments, very creative. Ontario has these family health networks. They're really quite good, quite interesting. And then all of you there, Akron, Ohio's there today, I know, and San Diego, Dr. Woot, and some of the things going on in San Diego. So there's lots of examples, but we need to learn from each other quickly. So I'm going to end on a bold proposal. I know some people are beginning to think of wellness trusts in communities, in which through taxation or even social bonds, funds would be created for the community to invest in health. And that is terrific. More of that needs to occur. It should incent a lot of the insurers and others that if the denominator is a pool of people that eventually you're going to be insuring and providing care to, if there can be resources in terms of health and all policies to make sure under these new models now these people don't get sick to begin with, everybody benefits. Or if they do get sick, they're in a better resilient state to recover than they would be otherwise. But that's not what I'm talking about here. I mean, that's important, but a companion thing is I would like to see a proposal under these CMS payment innovation grants that are coming down the pike of risk-adjusted population-wide health budget overseen by some entity tied to multi-year performance targets. And you see an example of some of the targets there, okay? And so this would be let's take Madison, Wisconsin, where David spent much of his career, the Dean Health System, the others, I don't know all the parties in Madison, the FQHCs, all the other players there would say, we're going to apply for one of those, we're going to be accountable, and maybe we don't do it across the board, maybe we just do it diabetes, asthma, or whatever, but we're going to pool the funds. And we're going to work out a model to share the savings, etc. That's what I mean by a risk-adjusted population-wide health budget. That would be greatly facilitated if there was also a wellness trust operating in the same community. So just to show you, it's not pie in the sky. This is the one of the work groups we've been working with in California, the next slide. And we rated these on a scale from 1 low to 10 high, payment reform ideas. And these ideas have actually come out quite high. We had some others around 8, but others were around 6. So create accountable care communities, similar maybe to what Oregon is doing, focused on population health, that got a 7.5. Pilot incentives in a community to link delivery system and community efforts to improve health, that got a 7.0. And when we asked, is your organization, and these were a wide variety of organizations. I apologize if you can hear the noise in the background. It just lets you know we're in Berkeley. Is your organization attempting to link patient care with private or public community efforts to improve population health? 2/3 said yes. Now, we don't know how substantial those are, but it's much higher than I would have expected. So this is something we're working on in California. We'll see if this survives and becomes a part of our proposal. There are 2 or 3 communities out here that I think could engage in something like this. And San Diego is one of them. I'm sure Dr. Wooten will talk more about that. Perhaps Alameda County up here in the north, perhaps a part of Orange County back down in the south. So the key challenge, and I'm going to end on this pretty much, is this here, as David knows, and the early work in the Community Care Network. How do you build these needed partnerships? Because as far as we know, the evidence, the science around this, the research, is developing those shared goals, developing the shared information, making available or stimulating the innovations in the use of human resources, community health workers, and so on, promotorists. And most importantly, and I think the rate limiting factor, even more so maybe than lack of financial resources, is the lack of cross-sector, cross-boundary leadership. Not silo leadership. We have a lot of people that know how to achieve an individual organization's goals. What we now need is the cross-sector, cross-boundary leadership that's really going to activate health in all policies. So the last slide is just a thank you of what we all would like to see, healthier lives in a safer world, and that happens to be the Campanile out here on the Berkeley campus. So let me end there and open it up for whatever time there might be for questions. Thank you.